Is it Bluetooth or something? Or?
Winter's Day. We did have a panic where we wondered if anyone would turn up, so it's great to see so many of you here this evening. And this evening, Ceva would like to welcome Emily Dutton here to speak to us about Dead or Alive, the myths and modern treatments of mitral valve disease in golden oldies. Emily Dutton became an RCVS specialist in 2016. She runs her own mobile service and loves all aspects of cardiology. This evening, Emily will be using PolEv, an interactive voting system. So if you'd like to get involved, and you can do this if you are watching on the live webinar, you can download the app for PolEv, and as Emily goes through the presentation, there will be instructions on how you can get involved. And please do get involved. It's a lovely way of testing your knowledge without admitting it's yourself voting on the information. So that leaves me to ask you to join me in welcoming Emily this evening to talk to us.
Okay, well, thank you very much to Ceva for sponsoring this evening, because without them, we wouldn't all be here. And again, thank you very much for making it tonight with all the snow. We were wondering whether it would still be on, but thank you. We appreciate the fact that you've driven through hazardous conditions to get here. So the title of the talk, The Myths and Modern Treatments of Mitral Valve Disease in Golden Oldies, came about because I'm a peripatetic cardiologist, and on my travels I'd heard a few myths, in particular about spironolactone. But I'm also really excited to talk to you tonight about a novel treatment for mitral valve disease, which is really exciting, and I'm going to speak about that in the second half. Okay? I think it may revolutionise what we advise for treating mitral valve disease patients in small animals. The Dead or Alive part was to add a musical component for those of you old enough to remember the band, but it was also a minor attempt at a dramatic talk title to draw you all in this evening as well. So I'm actually going to do things slightly differently tonight. I'm going to start and talk to you with my owner's hat on rather than my cardiologist hat on. And I'm going to present to you my golden oldie. This is Winston. He's 16 years and 4 months of age. And he's been a fantastic little dog, and he's grown up with my 2 children who are slightly younger than him. And he's going a little bit deaf, and he can't see very well, and he's arthritic, so he can't walk very well either. But as I say, he's been great. Last summer, however, we thought we were going to lose him. Now, it wasn't to mitral valve disease. It was actually, he had some neurological episodes. And he recovered really well, though, except for a minor head tilt before these photos were taken. He's still doing great, and he's had a great quality of life for the last few months. So what my point is that we spent last Christmas with Winston, and we didn't think we'd have him with us. And those extra few months have really meant the world to us. And I guess when you're presented with a heart failure patient, we probably are only talking a matter of months. And it's about good quality months, and we also ideally want to give them a longer quantity as well. So it's quantity and quality of life. And as I said to you earlier, after the break, we're going to talk about this new treatment, which hopefully will give us longer than a few months with these patients. So with my cardiologist hat on now, I'd like to draw your attention to an online survey that Ceva performed last year. It highlighted a few of the myths that we've heard about spironolactone. So the survey, some of you may well have completed it. It was sent out to vets in general practice last March. They had 100 respondents, and it took about 10 minutes to complete. The eligibility criteria were you had to be a full-time vet, working in practice, spending at least 95% of your time on first opinion work, and you also had to be spending at least 3/4 of your time with small animals. It could be an owner, a director, an assistant replying, but you had to have been at least 3 years qualified, and you had to be making decisions with regards to the medication stocked in the practice. So the question that Ceva asked was, for a dog in stage X of heart failure, what is your typical medication protocol? And you can see here the column on the left, we can see the various stages of heart disease, and I'll run through the ACVIM classification system on the next slide for those of you who may have forgotten. And we can see here that the 4 main heart failure drugs are pimabendin, ACE inhibitor, furosemide and spironolactone. And there were 2 things that struck me on this survey. First of all, there are still people prescribing furosemide and spironolactone in stage B2. Okay, so stage B2 is before there's heart failure present. Okay, so it's when the heart is enlarged but there's no heart failure. And there is absolutely no need to prescribe diuretics during this phase. The only evidence we have at the moment for stage B2 will be administration of pimabendin, and that's following the EPIC study. However, what was reassuring was that most vets were prescribing loop diuretics in stages C and D, so these are the heart failure stages. So I'm just going to run through the various stages with you now. So a few years ago, we had a publication describing the ACVIM classification system of mitral valve disease. And there were 4 stages, broadly speaking, A to D, and as you follow the arrow along from left to right, the mitral valve disease progressively worsens, okay? So we'll start off with stage A. Generally speaking, stages A and B, there's no heart failure present, and stages C and D, there is heart failure present, okay? Stage A are the at-risk breeds, so for example, Cavalier King Charles and Chihuahuas. You may have a Cavalier King Charles puppy, so it's not got mitral valve disease, it hasn't got mitral regurgitation, hasn't got a heart murmur, but it's at risk of developing the disease. Okay, so that's stage A. Then we have stage B, which we can subdivide into B1 and B2. So stage B, they've got a heart murmur due to mitral regurgitation due to mitral valve disease. Stage B1, there's no heart enlargement, and stage B2, there is heart enlargement. Okay, but remember there's no heart failure because we're stage B. Then we move on to stage C, so they're progressively worsening, and these patients now have heart failure or have had heart failure present, so they may be in compensated heart failure and treated. And then finally we have the end stage cases, the stage D cases. Now these are the ones that are refractory to heart failure medications, so those 4 medications I showed you on the last slide, and they're worsening. So what is heart failure? Well, broadly speaking, the definition of heart failure is a state in which cardiac output cannot meet the demands of the body. There are many terms. We have systolic failure, diastolic failure, forward, backward failure, right-sided congestive heart failure, left-sided congestive heart failure, acute and chronic. So we've got lots of descriptive terms, but basically, if the patient isn't showing clinical signs, then there's no heart failure present, okay? Now, when we're talking about mitral valve disease, we're talking mainly about left-sided congestive heart failure, other than the dogs with pulmonary hypertension, of course. Because you have mitral valve disease, you have mitral regurgitation, they develop a large left atrium, and then eventually you get pulmonary venous congestion and heart failure. So the signs that we're talking about when we are describing heart failure due to mitral valve disease are many, one of which may be a cough, but it's really, really important that you don't rely on a cough as a sign of heart failure, because there are many dogs with mitral valve disease and a murmur of mitral regurgitation that may be coughing due to a primary respiratory disease. Okay, so bronchomalacia, bronchitis, there are many different causes of a cough, so please don't rely on a cough alone to diagnose heart failure in a dog with a heart murmur. So I need to thank Luca Ferrison for this diagram here. It shows very nicely the cough receptors in the dog. Just to discuss coughing a little bit more, broadly speaking, when we're talking about heart failure and a cough, or heart disease and a cough, there are two main causes or cardiogenic causes of a cough in dogs. One will be due to cardiomegaly or left atrial enlargement in particular, causing left main stem bronchus compression. So these may be B2 dogs, they're not in heart failure, but the heart is enlarged. Okay, so that's number one. Number two will be due to heart failure itself, so pulmonary congestion and flooding of the lungs, stimulating the bronchopulmonary C fibres or the cough receptors and causing a cough. Now, just to show you on this diagram, most of the cough receptors in a dog are actually in the upper airways, not in the lower airways. So for there to be a cough due to heart failure, you have to have an awful lot of fluid, okay? So there is a little bit of controversy with respect to coughing dogs and heart failure, just so you're aware. By the time these stages C and D dogs are in heart failure and there's flooding of the lungs and that's causing a cough, they're principally dyspneic. So we actually suggest that you look for dyspnea rather than a cough, okay? And that brings me on to this point here, which is that I think it's really difficult for owners to detect dyspnea in their dogs unless they've been trained to look for it. I've had medically trained owners, so doctors and nurses entering the consult room, their dog has a respiratory rate of 60 breaths per minute, it's clearly dyspneic, and I'll say to them, how long has your dog been dyspneic for? And they'll say, it's not dyspneic. So unless you're actually training them early, I think it's really hard for them to detect dyspnea. Which brings me on to sleep and respiratory rate. This has been shown to be sort of the gold standard for detecting heart failure in dogs with mitral valve disease. There's been a paper published to show that a cut-off value of over 30 breaths per minute is a good indicator that heart failure is present, obviously if the patient doesn't have underlying respiratory disease, that is. Okay, so when I see a dog and I diagnose B1 mitral valve disease, so that's mitral valve disease with a murmur but no heart enlargement, no heart failure, as soon as they're in B1, I start to train the owners to count sleeping respiratory rate because it takes a while. And there are other apps available, but I do like the Cardiology app, the orange and white heart. It's not the blue one when you suggest for them to download it. It draws nice little graphs for the owners. They can see trends because it is very variable, sleeping respiratory rate. And you will also find that some dogs, their normal is 40, but generally speaking, less than 30 breaths per minute suggests that heart failure is not present. And then finally, there's exercise intolerance as another sign of heart failure. But again, these are old dogs we're talking about, like Winston. They're slowing down anyway. They can't see very well and they may be arthritic. So again, lots of owners will put exercise intolerance down to age. So just to talk you through some plumbing of the heart and to sort of run through the process of heart failure, I've drawn you a little diagram here. You can see the left heart's in red, and we've got the left atrium, and obviously normally that will empty the blood into the left ventricle. The mitral valve will close, the left ventricle will contract, the aortic valve opens, and the blood will pass around the body. As you know, the pulmonary veins will carry the oxygenated blood from the lungs into the left atrium. So, over time, not all B1 mitral valve disease dogs will progress. That's number one, okay? But for those that do, some of them will progress. They'll get mitral valve regurgitation, and that volume will increase, The left atrium may get dilated, but as I said, not all dogs with mitral valve disease will develop a dilated left heart, but a proportion will. And then you'll get pulmonary venous congestion because the left atrial pressures are high and obviously everything's trying to drain from the lungs. And as a result of that, we'll get high hydrostatic pressures in the venules and then alveolar edema and congestive heart failure. So remember that heart failure in dogs with mitral valve disease only really occurs when there's severe disease present. So they've either got a very big left heart, a big left atrium, or they've maybe ruptured a cord, but there has to have been severe disease there. Not all B1 dogs will go on to develop heart failure. As cardiologists, we're really quite obsessed about measuring left atrial diameter, and there's a reason for this. It is a prognostic indicator. The bigger the left atrium, the higher the risk of heart failure. So the left atrial diameter will inform us about severity of the disease. There are other things as well, like severity of mitral regurgitation, but we do pay a lot of attention to the left atrial size. So I'm not going to teach you all how to diagnose heart failure. I'm sure you all know how to. But to differentiate a B2 dog that hasn't got heart failure but has got an enlarged heart from a stage C dog, which has got heart failure present, in some cases it can be quite tricky. And thoracic radiography and echo obviously will be the gold standard for that. As a cardiologist, obviously I like echocardiography. And so it will not only tell me about chamber size, but it will give me an underlying diagnosis as well. And if there are any effusions, I will be able to see that too. So there's a huge variety and range of mitral valve disease. And I'm going to show you 3 different dogs now with all the same presentation, okay? None of them are symptomatic, but they've all got a grade 4 pansystolic left apical heart murmur. So this is the right parasternal short axis view that we measure left atrial size from with cardiac ultrasound. And what we do is we measure the left atrial diameter and we divide it by the aortic diameter and we get a ratio called the left atrial to aortic ratio. And you can see here I've calculated it and it's 1.3. The normal left atrial to aortic ratio in a dog should be less than 1.5. Okay, so this dog has got mitral valve disease. It's got a grade 4 pansystolic left apical heart murmur, but it's stage B1 because its heart is not enlarged. Next, we have a dog with a grade 4 pansystolic left apical heart murmur, and you can see the LA to AO is big, it's 1.6. So this dog is a stage B2, and it would benefit from pimobendan. And then finally, we have another dog with no symptoms, grade 4 pansystolic left apical heart murmur with an LA to AO of 2.3. Now, I am really worried about this dog. Okay, this dog is on the verge of developing heart failure. It hasn't got it, it's asymptomatic, but I'm really worried about it. So not only am I going to start pimobendan, I'm going to ask the owner to religiously count sleeping respiratory rate every night, come back after a week, I'm going to recheck that dog more frequently, and obviously be aware that this dog is at high risk of developing congestive heart failure. So although all 3 dogs had the same presentation, without staging them, you're not going to know what to treat them with, and you're also not, we're going to recheck them differently as well. Okay, so it's not just about treatment, it's about rechecking them as well. For those of you without cardiac ultrasound, you might want to perform thoracic radiography. And that's good too because you can assess the lung fields. So I'm going to show you now how a normal heart looks. I need to thank the vet who kindly let me reuse this radiograph, Jack. I don't know if Jack's here tonight, but thank you, Jack. So you can see here the right lateral thoracic radiograph shows a normal left atrial size. We can see sloping downwards of the trachea away from the backbone, and I've highlighted the left atrium for you there. Next, we've got the DV, and you can see the left atrium here between the caudal main stem bronchi. And then now we've got a dog with moderate left atrial enlargement. Okay, so we're starting to see now loss of the normal gentle curvature of the caudal margin of the cardiac silhouette. And we're starting to see the trachea is being elevated towards the backbone. And on the DV, we can see separation of the bronchi. And then finally, this dog presented in congestive heart failure due to mitral valve disease. So it had severe mitral regurgitation and a very dilated left atrium. And you can see here, there's an increased height of the caudodorsal border of the cardiac silhouette and this left atrial wedge there. And obviously, it's important to assess the lung fields as well. So with heart failure, you'd expect an increased vascular pattern, maybe an interstitial pattern. You might see cardiogenic pulmonary hilar edema as well. So here you can see separation of the caudal main stem bronchi due to severe left atrial enlargement. So in contrast, this is a Jack Russell Terrier with a grade 3 pansystolic left apical heart murmur, coughing and exercise intolerant. And I think you can quite clearly see here, both from the echo and the radiograph, that the left atrium is a normal size. And actually the vertebral heart sum for this dog was 10.5. Now it's a terrier, they do have quite rounded hearts anyway when you look at them radiographically. And lung field wise, it had a diffuse bronchointerstitial pattern. So when you're looking for a bronchial pattern, remember to look for your tram lines and your donuts, your end-on bronchi. And so because it had a normal left heart, we knew that it wasn't coughing due to heart disease. So the heart murmur was clinically insignificant. So we advised a respiratory workup, bronchoscopy in a bowel, and we diagnosed bronchitis. So obviously the treatment there is different. The treatment's going to be inhalers. And as I said, this dog was coughing and exercise intolerant because of the respiratory disease, not the heart disease. So imaging is important. So I've digressed a little bit. I'm going to take you back to the Ceva survey. And I just want to show you the stage C dogs here. You can see here that 45% of vets prescribe spironolactone during stage C. So stage C is when they're in heart failure. There were two main reasons for this that Ceva looked into. One was cost to the owner. I think you can all appreciate the problems we have when we want to treat dogs with certain medications and there are financial constraints. And the other one was owner compliance because of polytherapy. So I think obviously it's a little bit of a myth with regards to cost because there are combination drugs available, and I looked at the price of Cardiology. As you know, Cardiology is spironolactone and ACE inhibitor. It's about the same price as an ACE inhibitor. And owner compliance, that's really underestimated. The Mark Oyama's group published a study to show that people do get really very stressed. Owners get very stressed when you prescribe multiple medications. So polytherapy is very, very stressful for an owner. So obviously the less the tablets you prescribe, the better for the dog and for the owner as well. And then what drew my attention really from this slide was that 22% of people said, I don't prescribe spironolactone because I don't need to, because I've prescribed furosemide. Okay, now this is a myth. Okay, spironolactone is not prescribed for its diuretic effects. It is not a strong diuretic. Furosemide is a loop diuretic, it is, but we prescribe spironolactone because it's an anti-fibrotic, and I'll talk you through that later. But first myth of the evening, spironolactone is a strong diuretic. That's false. Certainly for the acute heart failure stage, I wouldn't be reaching for spironolactone, I'd be reaching for a loop diuretic. So, when a patient has heart disease, not all of them will go on to develop heart failure, but a certain proportion will. And when they do, there are multiple cascade systems which are activated. And these are both neurally mediated and also hormonally activated processes, okay? And they are in response to a drop in blood pressure. As the heart disease progresses, they develop heart failure, the blood pressure drops, and the body tries to respond by activating these systems. So I'm sure you've all heard about renin-angiotensin-aldosterone system, or RAS. You get RAS stimulation, you get increased sympathetic nervous system, and you get aldosterone release as well. Now remember, aldosterone will cause sodium and water retention, so by doing that it will help elevate the drop in blood pressure. And also with RAS, angiotensin 2 is a potent vasoconstrictor, so that will also help elevate blood pressure, which is dropping. But the problem is you get this over-exaggerated response, and so you start to get fluid retention, and that's when you get body cavity effusions and obviously heart failure. So the body's trying to return the blood pressure back to normal, and by doing so, by increasing sodium and water retention and vasoconstriction, you get worsening signs of heart failure. The other thing I wanted to mention was that if you prescribe or administer furosemide, furosemide will actually activate the RAS system itself. So it's another good reason not to prescribe furosemide during stage B. So just want to show you where the different diuretics work. So first of all, we have the loop diuretics, which work on the loop of Henle. Then we have the thiazide diuretics, such as Modurette. So Modurette is a combination of hydrochlorothiazide and amiloride, and it works in the distal tubule there. And then finally, we have the potassium-sparing diuretics like spironolactone, which work on the collecting duct. And as you move along the arrow from left to right, you can see there's decreasing potency. So why do we prescribe spironolactone if we're not prescribing it for its diuretic effects? Well, spironolactone is an aldosterone receptor antagonist, and if you remember, I said that aldosterone's a baddie. It causes sodium and water retention, it causes fibrosis. So spironolactone will counteract that. So the main reason we prescribe spironolactone during stage C is for its antifibrotic effects. It blocks cardiac remodelling, it blocks electrical remodelling, it decreases vascular fibrosis and endothelial fibrosis, and sort of less importantly, it's vasodilatory and it's a weak potassium-sparing diuretic. So why are we so bothered about reducing myocardial fibrosis and blocking electrical remodelling? Well, this is an example here, okay? So we can see in ECG, this is a dog with advanced mitral valve disease, and you can see the first two complexes are normal sinus complexes, and the third one along is premature. It's wide and bizarre, it's coming from the ventricles. So it's a VPC, a ventricular premature complex. Now we think that by blocking electrical remodelling, we're going to help prevent these types of arrhythmias. So if you had a run of these VPCs, you'd have ventricular tachycardia, ventricular fibrillation and potentially sudden death. So we think that by administering spironolactone, we may help prevent sudden death in these heart failure patients. The other point to discuss as well is that by reducing myocardial fibrosis, you're actually making it easier for the heart to work. Because if you have so normally the left atrium will pump blood into the left ventricle, and the left ventricle is nice and elastic and it will fill nicely and easily. But if you have fibrosis over time, then the left ventricle is not going to fill as well. You're going to get a restrictive filling pattern. So the left atrium is not going to be able to empty as well. And of course, then it's going to get bigger, and then you're going to increase your risk of heart failure. So this is why reducing fibrosis potentially will help, particularly the stage D patients as well. Okay, so what evidence is there it works? In 2010, we had the BVM&S study, which looked at mitral valve disease dogs with congestive heart failure due to mitral valve disease. And half of them were administered placebo, half of them spironolactone. This was in addition to a loop diuretic and benazepril. So these were the days before pimabendin. And the spironolactone group, they had prolonged survival versus the placebo group. What other evidence is there for other medications? Well, back in the 90s, we had the ACE inhibitor studies, so COVE, IMPROVE and BENCH. And again, these were all dogs with mitral valve disease and heart failure, and those dogs that were administered the ACE inhibitors had prolonged survival. Now, there's been a lot of criticism about these studies because obviously they were last century, so the designs maybe weren't as good. They had mixed populations, they had DCM as well as mitral valve disease, and they were small numbers as well. However, at the time, at the end of last century, we were treating heart failure patients with furosemide ACE inhibitor plus or minus digoxin. And those were the days before pimabendin. Then in 2008, we had the results of the QUEST trial. And that was when pimabendin came out. And we had, so this study looked at mitral valve disease dogs with stage C. Half of them were administered pimabendin, the other half an ACE inhibitor as well as diuretics. And you can see by the orange survival curve that the pimabendin group had prolonged survival by a few months. So the QUEST study told us that pimabendin was better than an ACE inhibitor, but what it didn't tell us was whether pimabendin and an ACE inhibitor was better than pimabendin alone. Okay, so all of these studies have got their limitations. So generally speaking, when you speak to cardiologists, the majority of them will still prescribe ACE inhibitor and pimabendin to a patient in heart failure. Okay, it's only if there's cost constraints where you need to decide it's one or the other that you would choose pimabendin over the ACE inhibitor. So the standard treatment for congestive heart failure due to mitral valve disease, well, as I mentioned, we had the BVM&S study, so we now advise spironolactone, we advise an ACE inhibitor, we also advise pimabendin, no studies, but we advise a loop diuretic, okay? So each one of these studies, they all had their limitations. So spironolactone, there wasn't pimabendin, the ACE inhibitors didn't have pimabendin, and the QUEST trial with pimabendin didn't look at pimabendin with an ACE inhibitor. So each one of those studies, none of those studies were perfect. So that brings me on to furosemide. Okay, we advise furosemide for any patient in heart failure, but this is a general consensus. It's not based on any evidence whatsoever. But we've all agreed as cardiologists that it wouldn't be ethical to leave a dog in heart failure suffering and drowning. So loop diuretics remain the cornerstone therapy for heart failure therapy. So we do actually have one study very recently, the TEST study in 2017, and this was looking at a new loop diuretic called furosemide versus frusemide. Now, it wasn't a superiority study, it was just an equivalent study. So it's looking at whether toracimide administration to patients in heart failure was as good as administering frusemide. Okay, so it's comparing the two loop diuretics, and it was shown to be equivalent. Okay, we don't have a superiority study though. But what's nice now is that we do have the choice of two loop diuretics. The downside of toracimide is we don't have an injectable form, so we are reliant on administering that only for those stable or chronic heart failure patients, so we don't really tend to use it in the acute situation. Right, so I'm going to ask you all, and those of you online as well can join in. If you go onto your mobile phones and in your web browser, whether it be Safari or Chrome, Google Chrome, if you want to just type in this email address at the top here, or web address I should say, and it will ask you to log in. So you don't need to log in, just press skip. So hopefully you've all got a phone. There's lots of concentration going on here. Okay, so it's polev.com/, well, it should probably just come up Emily Dutton anyway, but just put polev.com, okay? You ready? Yeah? Nearly? I'll just give it a couple more minutes. So it's polev.com/Emily Dutton 724. You don't need to log in, just press skip. Okay, we ready? 50% I'd say already. I think we need some more coffee. Right, I'm going to go now, okay? So the first patient, that slide will come back, don't worry. The first patient is an 11-year-old female new to Bichon Cross. Okay, so it presents to your colleague actually, it's got a cough. On clinical examination, the locum writes in the notes there's a grade 3 pansystolic left apical heart murmur. Heart rate's 100 beats per minute and regularly irregular but in time with the breathing, so that suggests sinus arrhythmia. The respiratory rate's 12 breaths per minute. There's a mildly increased respiratory effort, good pulse quality, no deficits, abdominal palpation unremarkable, body condition score 5 out of 9. Okay, so the owners refused diagnostic investigations. Okay, so the locum prescribed a 3-day course of frusemide, and the owner came back to see you. They reported a reduction in the cough frequency following the frusemide administration, but since they stopped the 3-day course, the cough is back. What would you do next? Okay, so if you want to go back, just refresh your browsers, and hopefully it should come up. And just press. You don't need to log in. Just skip. Oh, it looks like you've already voted. Oh, here we go. So this is live, and people at home can vote as well. Getting some indecisiveness here. Okay, that's really interesting. Have you all voted? Okay, so the majority of you said that you would strongly advise further investigations. We're getting some people who are undecisive about whether or not to prescribe additional cardiac medications. There are 8% of you want to carry on prescribing oral frusemide long term. Nobody wants to prescribe spironolactone instead of frusemide. That's D. Okay. So I would definitely advise further investigations, okay, for several reasons. One, the dog had sinus arrhythmia, and that's a strong indication that heart failure is absent, because when you have sinus arrhythmia, that suggests high vagal tone. Remember, when they go into heart failure, you get a reduction in parasympathetic tone and an increase in sympathetic tone. So often sinus arrhythmia will be abolished when they go into heart failure. So that's a nice, easy test, although you can't 100% rely on it. The other thing was that with respiratory disease, with primary respiratory disease, you often have high vagal tone as well. So that would be another indication that maybe the cough was due to primary respiratory disease and not heart failure. And finally, the dog's respiratory rate was 12. And again, we said earlier that patients with heart failure, the respiratory rate's over 30 usually. So you could say, well, maybe it's a stage B2 dog and it's not in heart failure and it's coughing because it's got a big heart. Well, that's true, but it's equally true it could have had a heart murmur and primary respiratory disease with a normal size heart. So without doing further investigations, we don't know. Now, this brings me on to another myth, and I'm really glad that none of you actually clicked on the last option, which was I would prescribe spironolactone instead of furosemide, because I have heard on my travels that apparently spironolactone is used to treat a cough, and that is false, okay? Again, it's a weak diuretic. We don't tend to use it to treat coughs. So this Bichon cross, we did perform thoracic radiography and also echo, and the echo showed it had mitral valve disease but a normal size left heart, so the cough was not due to heart disease. And what you can see here, and I think this is beautiful, you can see this increased interstitial pattern in the peripheral lung fields, okay? Now that is suggestive of lungworm, of Angiostrongylus visorum. So a small reminder, you can have normal thoracic radiographs and still have lungworm. Okay, so just because you have normal lung patterns does not rule out lungworm. So you do need to perform additional tests. So your Behrman fecal flotation test, and also there's the angiodetect test now. And this dog came back as positive for angiostrongylosis. And what was particularly interesting with this dog is it had no travel history. It always lived in Cheshire. So for those who are here from the northwest, you'll know that we don't really see lungworm as much as, say, if you're in Devon or Cornwall and you're listening. But we are starting to see it more now around here. So this is the left lateral, and again we've got this beautiful haziness here in the peripheral lung fields. So why did the dog respond to furosemide? I can hear you all asking. Furosemide is an antitussive, okay, so it will reduce cough frequency. So this is another case example, so if you just refresh your browsers. This was an image from an asymptomatic 6-year-old cavalier with degenerative mitral valve disease. So you've got the diagnosis. The left atrial to aortic ratio was 1.65. How would you manage this case? So LA to AO is 1.65. Would you A, do nothing because the dog is asymptomatic, B, prescribe benazepril, C, pimabendin, D, furosemide, or E, a combination of the above? Oh, you're very... Ooh. Got some rebels at the back, I believe. Okay, I love the way that everybody changes their mind. It's great. Apparently, we have to have a 20-second delay as well for online for people who are watching at home. So I'm just going to wait a few seconds. So it does look like Boehringer have done a good job and told everybody about the EPIC study, because the middle answer is the correct answer, pimabendin. This dog has got left atrial enlargement. Remember, the cutoff for a big left atrium was 1.5. This dog, I think, was 1.65. Now, in the EPIC study, they used a cutoff of 1.6. So anything bigger than 1.6 is big, a big left atrium. And so they showed in the EPIC trial that administering pimabendin during stage B2, so they're asymptomatic, but with a big heart, delays onset of heart failure by 15 months. Okay. So there's no other evidence at the moment for any other medication during stage B2, during the asymptomatic stage. Okay, so for those of you who like echo, you can also measure left ventricular diameter during diastole and normalise to body weight, and the cutoff for that was greater than or equal to 1.7. So in summary, staging mitral valve disease is important. It will alter the treatment plan, and also it will affect prognosis depending on the results. And although I'm sure that Boehringer would absolutely love it if we all prescribed it during stage B1, so as soon as there's a heart murmur present but there's no heart enlargement, there's absolutely no evidence for any treatment whatsoever during stage B1 or stage A at the moment. Okay? I am awaiting with anticipation the results of the DELAY study, which I'm hoping might be out at the end of this year. And DELAY, have you all heard of DELAY? No? Okay, so this is run by Ceva, and what they're looking at is they're looking at whether a combination of benazepril and spironolactone during stage B2 will delay onset of clinical signs, because remember, B2, they haven't got heart failure. Okay, so that will be interesting to see. But I think it's probably time just now for a quick 5-minute coffee break. And after the break, we're going to do lots more interactive case reports. And we're also going to talk about stages C and D. And also I'm going to tell you about the novel therapy for mitral valve disease as well. So if we all want to rejoin, for those online, maybe in about 10, 15 minutes. Okay, so we'll have a quick coffee break. Yeah. Right. So hopefully you've all had your caffeine now. Hello, at the back. Hello. Hopefully you've all had your coffee now. You're awake. So in a few slides' time, I'm going to make this case interactive again. But I want to talk you through the Hamlet study. Have you all heard about the Hamlet study in this room so far? A few little nods, a few shakes. Okay, I'll talk you through that as well. So this particular cavalier was a 5-year-old female neuter cavalier, and she was referred for investigation of a grade 3 pansystolic left apical heart murmur. The murmur had been a grade 1 6 months prior to presentation, and this particular dog was asymptomatic, so she was potentially a Hamlet candidate. So, what is the Hamlet study? Apologies to those of you who have already heard of Hamlet, but it's basically a study to help differentiate B1 dogs from B2. So remember, B1 are dogs with mitral valve disease but no heart enlargement. B2 are mitral valve disease dogs with heart enlargement and neither have got heart failure. They are using a combination of clinical criteria, but in particular cardiac biomarker concentrations to help discriminate the two. So this will be very relevant to general practitioners, because if you have an asymptomatic dog at a booster that has a murmur and maybe the owner's umming and ahhing whether or not to pay for an echo, if you can say, well, we'll take this blood test and we'll send it away, and it might help us decide whether your dog needs to urgently see a cardiologist or less urgently see a cardiologist, and it might help you decide which of the dogs need seeing more quickly than others. So it will be relevant. And obviously, I'm sure, hopefully you understand the Hamlet theme, B2 or not B2. So we either get giggles or groans whenever I say that, so you're gigglers, that's good. So I'd like to thank those of you here who've actually already helped me recruit cases. Apparently we're in the top 3 in the UK, so thank you very much to those of you here, the Northerners and people in Cheshire who've helped me recruit. So the inclusion criteria are they have to be over 6 years of age, and they have to have a left apical pansystolic murmur with a maximal intensity over the mitral valve. And they need to weigh between 2 kilo and 25 kilos, so it's not limited just to the Cavalier King Charles, so it's not just the 10 kilo dogs. The echo criteria, you don't need to worry too much about that, that's more for me, but the owners need to pay for the echo, so I'm afraid that's not free of charge. But what the owners do get is free biochemistry, electrolytes and biomarker tests. Most importantly, the dogs can't have any clinical signs of heart failure, and they can't have had previous furosemide administration. So again, another reason not to administer furosemide. Okay, otherwise we can't accept them. So the free blood tests have actually proved quite handy, because remember, these are quite old dogs with mitral valve disease and they have comorbidities. So we've actually picked up quite a few with renal failure and Cushing's through the tests that maybe the owners wouldn't have otherwise paid for. So going back to this case, 5-year-old female neuter cavalier, referred for investigation of a grade 3 pansystolic heart murmur. She's asymptomatic. She'd had no medications, which was great because it meant we could use her for the Hamlet study. She needed a dental, so the referring vet actually was bothered about systolic function, heart enlargement, and whether or not, obviously, if this dog did have an enlarged heart, whether or not it would benefit from pimabendin for a couple of weeks prior to a general anaesthetic for dental. And obviously, if you're planning anaesthesia as well, you might want to know whether or not there's mitral regurgitation, because it will affect your intravenous fluid rates as well. So investigations were performed, obviously your standard heart workup, so blood pressure, ECG, echo, and the blood tests which were free for the Hamlet study, biochemistry, electrolytes. They don't run haematology. And we found that the dog had a high blood pressure, so it was measured indirectly using the Doppler technique, and it was 220 millimetres of mercury. The dog was relaxed. We didn't suspect white coat hypertension at all. ECG fairly unremarkable, sinus arrhythmia at 110. And then the echo showed that she had, surprise, surprise, mitral valve disease with moderate mitral regurgitation. The left atrium was slightly dilated. You can see here the LA to AO is 1.55. Remember, the cutoff's 1.5. And I've written down there the reference range for the left ventricle. We measure the left ventricular diameter during diastole and systole, and you can see here that both values are marginally dilated. So she had a marginally dilated left heart and systemic hypertension. Systolic function was good. So to summarise, she had preclinical mitral valve disease with marginal left atrial and left ventricular dilation. Not enough to warrant pimobendan therapy. Remember, the cut-off for the EPIC study was an LA to AO of greater than or equal to 1.6, and she was 1.55. But she was hypertensive, and we repeated the blood pressure with the owner present just to be sure, and again she was relaxed and the blood pressure was still high at 220. So my question to you is, if you all want to refresh your browsers, what would you do next? Would you A, prescribe amlodipine, B, investigate the underlying cause of the systemic hypertension, C, both of the above, D, nothing, a blood pressure of 220 doesn't concern me, or E, book the dental, the systolic function was good? Oh, 50-50. Okay. I love the way people change their mind, it's great. Ooh, got a little rebel somewhere. I'm just going to wait the 20 seconds for those at home. I think I've got too many options here. Oh, someone's changed their mind about booking the dental. Right. Peer pressure, I think. Right, okay, so it looks like the majority of you would do both of the above. I don't think there really was a right or a wrong answer. There was one wrong answer actually, which was do nothing, because a blood pressure of 220 would really concern me. I'd be really bothered about target organ damage, whether it be eyes, brain, heart. I wouldn't ignore a blood pressure of 220. But certainly I think I would agree with the majority of you here, which would be to do both of the above, so C. Now, we did carry out a retinal examination as well, because if they're hypertensive, obviously you might see changes at the backs of the eye, and this particular dog had tortuous retinal blood vessels as well, which obviously was quite reassuring when we measure a high blood pressure, that we aren't measuring it wrong. And you can also request a urine sample to measure urine specific gravity and also to check for protein in the urine. Remember that a lot of these patients with systemic hypertension, particularly the older dogs, may have underlying renal disease as well. Having said that, they may not have renal disease, but you may expect to see a little bit of protein in the urine if they're hypertensive, just from the hypertension alone. So, to summarise, we had preclinical mitral valve disease with marginal left atrial and left ventricular dilation. We have high blood pressure, and we've collected urine samples. And remember, we had the free blood test sent for the Hamlet study, so we have biochemistry and electrolytes tests as well. And that was quite helpful, because obviously you want to rule out renal disease. This is what the Hamlet results look like. If they're green, it means they're normal. And you can see at the bottom here that the SDMA was within reference range. The urine-specific gravity was 1040, so I was convinced this dog didn't really have any underlying renal disease, and there was a little tiny bit of protein in the urine, but again, that can be just due to the high blood pressure as well. So we treated the systemic hypertension. Obviously, we thought this particular case probably had idiopathic systemic hypertension. Remember, you want to rule out Cushing's and renal failure and all the other causes of systemic hypertension. But in this particular case, we were convinced it was idiopathic, so we reached for our first-line treatment, amlodipine. Now, I normally start for an average 10-kilo cavalier at half of this dose, but I was quite concerned about the blood pressure being 220, so I started a little bit higher. And then we rechecked the blood pressure a week later, and it was still high at 190. So you can then add in other, it doesn't have to be an ACE inhibitor, but we added in an ACE inhibitor at that point because of the heart enlargement as well. We thought it would be helpful to reduce preload and afterload. There are other drugs you can add in though. ACE inhibitors don't tend to drop blood pressure quite as well as amlodipine though, so I'd always go for amlodipine first line, and you usually get around 10, if you're lucky, 20 millimetre mercury drop with an ACE inhibitor. We rechecked blood pressure again, and it was still high at 180, so we increased the dose of amlodipine to 1.5 tablets twice daily, and we managed to normalise blood pressure. You don't always get such a great success rate trying to normalise blood pressure. And I'm not sure if you're aware, but they've actually reduced the cutoff now, and they're saying, or lowered the cutoff to 140 millimetres mercury. There's a new consensus statement that's out, it's in the Journal of Veterinary Internal Medicine. It's open access, so you can all have a read of that. but just so you're aware that it's 140 now. So there is another myth I've heard in my travels that spironolactone is used first line to treat systemic hypertension. That's false. So as a cardiologist, why am I bothered about systemic hypertension? So one of the views that we do when we echo them is from the left side. It's called the left apical 5-chamber view, and I've labelled the left atrium and left ventricle here for you. And on the next slide here, I've drawn a diagram. So we've got the heart upside down. When you have mitral valve disease, here's the mitral valve there, you get nodular thickening, which I'll show you in a second. But during systole, the mitral valve should close and prevent backflow into the left atrium, and the blood should go forward out through the aorta and around the body. So the aortic valve is open during systole and the mitral valve is closed. Okay, there's the blood going forward around the aorta. So with mitral valve disease, we get the nodular degeneration on the valve leaflets. And so during systole, you're going to get some leaking. So this is a dog with mild mitral regurgitation. You can see the bluey-green jets with the colour on this slide here. So on the left-hand side here, we have a normotensive dog with a blood pressure of 140. On the right-hand side, we have a dog with a blood pressure of 220. And the worry with systemic hypertension and mitral valve disease is it's going to affect your volume of mitral regurgitation. And the reason for that is in the normotensive dog, during systole, the aortic valve is open. The majority of the blood will flow forward through the aorta and around the body, and you'll get a small degree of mitral regurgitation. If you increase blood pressure, therefore you're increasing the pressure in the aorta and you're increasing afterload, the left ventricle then has to work much harder to pump that blood out through the aorta. So you get increased contractility and you'll get more volume of blood going backwards through the mitral valve into the left atrium than you will going forwards. And that's because the left atrium is a low pressure chamber and it's easier for the blood to go that way than it is to go forwards. And the problem with that is that you're going to end up with more mitral regurgitation, bigger left atrium, and then that blood's just going to keep going back into the left ventricle, back into the left atrium, and it's just going to stay in the left heart instead of going around the body. So you're going to get dilation of the left heart. And we spoke earlier about how left atrial size is a prognostic indicator. We don't want a big left atrium. Okay, it's going to increase your risk of heart failure. The other thing that increased volume will do, you'll get increased shear stress on the valve leaflets themselves, and they're already thickened and nodular and abnormal. So potentially you could actually worsen the nodular degeneration at the same time as increasing the volume of mitral regurgitation. So that's why we're bothered about systemic hypertension. This is a dog with severe mitral regurgitation. You can see the bluey-green jet. It's a huge volume. So let's imagine on that last slide it was the same dog with the same severity of mitral valve disease, okay, but you've increased the blood pressure. You can see the effect on the volume of mitral regurgitation compared to the same dog that's normotensive, okay? You're going to get less mitral regurgitation. So hopefully by controlling blood pressure, we reduce the volume of mitral regurgitation and we can potentially reduce heart size. And this is what we saw. So we echoed the dog 3 months later. Remember, the only treatment this dog has had is an ACE inhibitor and amlodipine. It's not had pimabendin, so we've controlled the blood pressure. And you can see on the left, the LA to AO is 1.55, and on the right, 3 months later, it's within reference range. So we didn't need to prescribe pimabendin for this dog. We just controlled the blood pressure. And you can also see the left ventricle has also reduced in diameter, both in systole and diastole. And if you see in the brackets there, we've got the reference range. It's now within reference range for that breed. Now, you might say, well, how about daily variability? You're going to get a bit of daily variability. My scanning technique will change. The dog's heart size will change if it's a bit dehydrated or whatever. And we do allow up to 10% change for daily variability. And this is an over 10% change. So I'm convinced that that's a significant change there. So why are we so bothered about heart size? Well, I said earlier about left atrial diameter. The bigger the left atrium, the higher the risk of heart failure. We think pimabendin works well because it's an inodilator. So it's not only a positive inotrope, it also vasodilates, so it makes it easier for the heart to work. And we know that pimabendin does reduce heart size. It reduces the annular ring diameter, and thereby it reduces the volume of mitral regurgitation, a bit like having mitral valve surgery, which brings me to this point now. And this, I think, is going to revolutionise cardiology, small animal cardiology. Now I need to thank Poppy Bristow from the RVC for the lower right hand side diagram here, and this shows you annuloplasty, which is mitral valve surgery. The black circle is the mitral valve annulus. You're looking down on the mitral valve annulus, and the little smiley bit there in the middle, that's where the anterior and posterior leaflets, the mitral valve leaflets, meet. Okay? When they perform mitral valve repair, there's a drawstring suture which you can see in the lower right diagram, and it kind of pulls the ring together, so it reduces the orifice size and thereby reduces the volume of mitral regurgitation. The other thing they do is they repair the chordae tendineae, because often these dogs will have either minor or major chordae tendineae rupture, and so that needs fixing too, so it will help hold the valve leaflets in place. So another interactive case. This is a 7-year-old Cavalier King Charles cross poodle, so Cavapoo. We're seeing lots of those now. Obviously these designer breeds are getting their own health problems, often similar to their parents, and now I'm seeing more and more because they're reaching a certain age. And this particular dog was referred for investigation of a grade 4 pansystolic left apical heart murmur. Okay, now at the vets, at the referring vets, it was breathless. It had a respiratory rate when asleep of 48 breaths per minute. And the vet radiographed it and diagnosed cardiomegaly. They prescribed furosemide and pimabendin prior to referral, and there was an associated reduction in the sleeping respiratory rate and also reductions in the respiratory effort to 28 breaths per minute. So thank you to the referring vet for allowing me to use this, and it clearly shows cardiomegaly. The vertebral heart sum was 13.25. Remember, in dogs it should be 8.5 to 10.5, but there are breed-specific ranges. Cavaliers, this was a Cavalier cross, their breed-specific range is a bit higher, so it's 10.1 to 11.1, so it was still a big heart even if it were a Cavalier. So you can see we've measured the vertebral heart sum here, it was 13.25. There's left atrial, left ventricular and right ventricular enlargement. There's also an increased vascular pattern. If you assess the cranial lobar pulmonary vein, it shouldn't be greater than the width of the proximal third of the fourth rib here, and in this case it was. Okay, so to summarise, when I saw it, it had a grade 4 pansystolic heart murmur over the left apex. Heart rate was 160 and regular, weak peripheral pulse quality, no pulse deficits, normal respiratory rate, so compensated heart failure, normal temperature. So we obviously performed a cardiac workup. Blood pressure was normal at 120, and you can see on the echo, I don't know if you're used to looking at echoes, but this is the right parasternal long axis view. We have the left atrium here, which is huge, and then we've got the left ventricle here, and we have thickened nodular mitral valve leaflets here. And it looks like even during systole, there's just a great big hole there, and that's where the mitral regurgitation would be. The left atrial to aortic ratio in this case was 2.1, so again it was big, the left atrium, so a guarded prognosis, and remember this is following diuresis and pimabendin therapy. We also ran an ECG which showed normal sinus rhythm, and biochemistry, hematology, electrolytes tests were all unremarkable. So this is a summary of the medications the dog was already prescribed when I saw it. It arrived receiving furosemide 20 milligram twice daily, and the owners were splitting a 40 milligram size tablet, and the pimabendin was 1.25 milligram twice daily. So we made a few adjustments to the medication. So I quite like the 10 milligram size tablets, particularly for the smaller dogs, because it means you can make small incremental changes to the loop diuretic dose. And I'm always trying to drop the diuretic dose to the lowest possible dose, just because of the side effects of loop diuretics. So because of a normal sleeping respiratory rate, the dog had controlled heart failure. So we reduced from 20 milligram twice daily to 10 milligram twice daily, but obviously asked the owner to monitor sleeping respirate really carefully when we did that. We optimised the pimabendin dose. We increased it to 2.5 mg twice daily. I tend to go for 0.3 mg BID dose, mg per kg BID for pimabendin. Because this was a stage C dog, we started spironolactone and an ACE inhibitor in the form of Cardiology. Now, because it's a 10 kilo dog and it's got a really big left heart, that 2.5 milligram of benazepril I thought was a little bit low, so I added in another ACE inhibitor in the evening, another 2.5 milligram. And you can also start omega-3 fatty acid supplementation to help prevent cardiac cachexia. Now, The only exception to that rule will be if there's a dog with pancreatitis. I then advised examination every 2 to 3 months with the referring vet for the vet to assess circulating urea, creatinine and electrolytes, because obviously we're on diuretics. We want to make sure that we don't have any electrolyte imbalance. And I also advised the owner to continue monitoring sleep and respiratory rate closely. Avoid salty treats, and we advise short, frequent walks. Before they go into heart failure, you can exercise them normally, but once they go into heart failure, I tend to advise short, frequent walks. So this is when the Cavapoo returns to see you. So 6 months later, so it's done quite well, it returns to see you. The grade 4 pansystolic heart murmur is now grade 5. So remember, grades 5 and 6 have a palpable thrill. Grades 1 to 4 don't have a palpable thrill. So it's got a grade 5 heart murmur. Heart rate's 160 regular. Pulse quality is still weak. Rest rate's now 38 breaths per minute. So it's got an increased respiratory effort as well. So possibly this dog has decompensated and now has heart failure again. And interestingly at the bottom I've put that the dog wasn't drinking or urinating as much as before. We had quite an astute owner here, so they'd noticed that. So we're going to vote. So if you want to refresh your browsers again. What would you advise next? Okay, would you A, increase the loop diuretic dose? Would you B, optimise the doses of the non-diuretic medications, so pimabendinase inhibitors? C, would you advise mitral valve surgical repair? Or D, a combination of the above? We'll just wait 20 seconds. Nobody's advising mitral valve surgical repair. Right, so I think the majority of you have elected for D, a combination of the above, and that's exactly what we did. So you're spot on. So the dog's progressing to stage D. Okay, it was stage C, it's now stage D because it was already on the 4 heart failure meds and it's becoming breathless again and tachypneic and dyspneic. So you do definitely need to increase the diuretic dose. So those of you who did vote for A weren't wrong, and certainly you can either increase the loop diuretic it's on, or you can maybe switch to the other loop diuretic, toracimide, which is also licensed. You know, either, it doesn't matter, but you do need to definitely make sure that you control that respiratory rate. That's really important. As this dog wasn't drinking and urinating very much, then we did suspect diuretic resistance, and I'll talk you through that soon. So we increased furosemide from 10 milligram to 15 milligram BID, and obviously owner constantly monitoring sleeping rest rate. We increased the ACE inhibitor dose to optimise that. That will reduce preload and afterload, and obviously it inhibits RAS. We continued the other medications, and we also advised mitral valve surgical repair. Now, the owner was very, very committed and had the money and the time to travel to the RVC. There's only one centre, and that's at the RVC, that performs surgical repair, and there's actually a really long waiting list. It's about, I think it's about 12 months, but it's constantly fluctuating. So it's something now I talk about to people during stage B1, and that's because if they're serious about it, then at stage B2, late stage B2 or C, that's when they need to be referred. The RVC actually don't want them during stage D because they're not doing well, because they've got such advanced heart disease. They're just not, they haven't got the success rates. So it is something I talk about, plus they also need to save up. So this is him now, and this was this month. He had mitral valve surgical repair last summer. He is off all cardiac medications. Okay, so this is looking amazing. Doesn't he look good? So just to talk you through mitral valve surgical repair, the 2019 price, it's not for the faint-hearted this, it's been capped at £17,500. So they obviously don't want the really old dogs, so really probably I shouldn't have put golden oldies in my talk title, because they do want the younger dogs really. The success rate for stage C currently, and this is hot off the press, it's not published, it's just verbally, 87% for stage C dogs, which I think is pretty good considering they then come off all the medications. The actual technique, Dr. Yuishi in Japan wrote up and published, and the success rates in Japan, they've been doing the surgical repair for much longer, is published at 93%, and that's the survival 3 years post-surgery. So these are patients that are either in heart failure or about to go into heart failure, and they're still alive 3 years post-surgery, 93%. It's absolutely phenomenal. So I really do think that this mitral valve repair is going to revolutionise the treatment for mitral valve disease. So the last case, I mentioned diuretic resistance, and we know that aldosterone escape is one of the many causes of diuretic resistance. It's not the only one, but I'm going to talk you through aldosterone escape. So we all know about RAS. Okay, I'm sure you're bored hearing about RAS, but basically you get RAS stimulation when they go into heart failure, and that's in response to a drop in blood pressure. And the whole point of RAS stimulation is the body's trying to counteract the drop in blood pressure by increasing it, again, by release of all these hormones, aldosterone, angiotensin II, okay? When you administer an ACE inhibitor, you're trying to prevent formation of angiotensin II, which is a potent vasoconstrictor, and you're also, by preventing angiotensin II, you're preventing aldosterone secretion. And aldosterone is a baddie because it causes fibrosis and it causes sodium and water retention, so you get the fluid overload, okay? So that's ACE inhibitor therapy, okay? What we do know is that a proportion of dogs will get something called aldosterone breakthrough or release, which is despite ACE inhibitor therapy. So even though a dog is receiving an ACE inhibitor, they still have increased circulating volume, circulating concentrations of aldosterone. And that's called aldosterone breakthrough. We know it happens in humans, and we know it happens in dogs, both with mitral valve disease, and in normal dogs it can happen as well. So there are publications to show that now. And the reason we're bothered about this aldosterone escape is because we think it's one of the many causes of diuretic resistance, because it doesn't just cause fibrosis in the myocardium and in the circulation, but it also causes fibrosis in the kidneys. So that may well be why they don't respond as well to diuretics. So the kidneys don't respond as well to diuretic therapy because we get something called nephron hypertrophy, and we think that's because of the aldosterone. The aldosterone causes nephron hypertrophy, and then your diuretics don't work as well. So what can we do when that happens? Well, I mentioned earlier thiazide diuretic modurate, which is hydrochlorothiazide and amiloride, and it works exactly on the spot where nephron hypertrophy occurs with aldosterone escape. So if you have a dog in stage D and they just can't afford mitral valve surgical repairs, it's not an option. They're already on a loop diuretic. You can add in modurate as well. It's a very weak diuretic on its own, but in addition to a loop diuretic, you'll get sequential nephron blockade. You do need to monitor electrolytes and urea creatinine very, very closely with these patients on multiple diuretics. It's really easy to make them hypokalemic, and then they'll go off the food, so that's not a good thing, and they get arrhythmias as well. So you do need to monitor them very, very closely. So, to summarise, with a patient with stable or chronic congestive heart failure, we use, excuse the language, SPAT or SPAF. Okay? SPAT is with toracimide, SPAF is with furosemide. So we have here, spironolactone is the S, pimobendan is the P, ACE inhibitor, and either furosemide or toracimide. Remember, toracimide is in a tablet form. This is why they're chronic congestive heart failure cases. You want to avoid salty treats, and you want to treat any arrhythmias, because for example, fast atrial fibrillation will make the heart failure worse. So it's very important you get heart rate control with maybe digoxin and diltiazem for your atrial fib. So that's the kind of the summary. You want to monitor circulating urea, creatinine and electrolytes. If you make any dose changes, do it a week later after the dose change, and then every 2 to 3 months ideally. With your acute heart failure patients, it's slightly different. You want the injectables. Obviously, you want to place them in an oxygen tent, or if they can tolerate it, a mask. And you're going to go for IV furosemide, so a loop diuretic in the acute stages. Now, I tend to, depending on the patient, if they come in and I think I can safely place an IV catheter, I will do that. And then I tend to go for 1 mg per kg IV hourly, whilst monitoring respirate very, very closely. Some patients you won't be able to get a catheter in, I understand that, so it might be safer to administer the first dose of furosemide IM until you're happy that you can safely place an IV catheter. But we do want to administer furosemide ideally IV because it's venodilatory when you administer it IV, so it will reduce preload, and so that kicks in before the diuretic effect even kicks in. For those patients that this is where a nurse comes in as well, because often they come in and you're busy, you're consulting, so I would always ask a nurse to sit with the patient as well and actually record and write down a number for the respiratory rate every 15 minutes so that you can see that the rest rate is actually decreasing. If it's not, I might then start a constant rate infusion of furosemide. Now, you do need an infusion pump admittedly, and you do need to sit with them when you start them on a constant rate infusion, but 0.5 to 1 mg per kg per hour seems to work really well in those that don't seem to be responding. IV pimabendin is something else you can give in the acute situation. It's an expensive way of administering the tablet, so I tend to say if it's safe to tablet them and they haven't got an abdominal effusion, then a tablet's absolutely fine. The absorption's within half an hour. But as I said, if they have an abdominal effusion, then I would probably think, well, the gastric absorption is not going to be as good, so I will go for IV pimabendin in that case. Make sure they have water to drink. Obviously, if there are any pleural effusions, abdominal effusions, if you think it's compromising respiration, then obviously you want to drain those. Now, some patients are very, very anxious. It's a horrible feeling not being able to breathe, and so some patients will benefit from very low dose opioid as an anti-anxiolytic. Anyway, you know what I'm saying. So it's worth doing that in some cases because remember, if they're stressed, it will increase heart rate further and that will worsen the heart failure. So it is important to keep stress levels to a minimum. And then you want to monitor respirate hourly. Once they've dropped down to, say, 40 breaths per minute, that's just my cut-off. I switch them then to oral tablets and remove them from oxygen, but that's just the way I do it. So thank you once again to Poppy Bristow for this intraoperative picture. This is the annuloplasty. We're looking down here at the mitral valve annulus. But ultimately, the optimal treatment for mitral valve disease may soon be mitral valve repair during stage B2. There are certain things that they're looking for, such as chordae tendineae rupture, and the volume of mitral regurgitation needs to be severe. So there are certain things we're looking for the echo to make sure they're candidates, but they've operated now on a few stage B2 patients. And actually, if you're a human with mitral regurgitation, they will advise mitral valve repair before you have any symptoms. So that would be stage B2 as well. So it's definitely worth considering and at least discussing with the owner. So it will be limited by cost, admittedly, and there is only one centre at the moment performing the surgery. So the limit is 1 to 3 dogs a week, and that's why the waiting list is long. But if you've got a very dedicated owner, the Cavapoo I showed you, he was prepared to drop everything and he got a cancellation, and that's why this dog is probably doing so well as well, because they operated quickly. I need to thank Virginia Louis Fuentes for these amazing 4D echo pictures. What you can see quite clearly is the hole. This is the mitral valve we're looking down through here. The hole in there has been repaired here. So this is post-surgery on the right-hand side. And on the left, you can see the large hole. Even pimabendin is not going to fix that hole. You need to physically perform surgery to reduce that orifice size and so reduce the mitral regurgitation. Right, so this is our final interactive case of the evening. This is a 9-year-old male neutered Daxi. Okay, previously diagnosed with advanced mitral valve disease. Okay, so this was 5 months prior to presentation. Returned for new collapse episodes. He was collapsing several times a day. They were very short episodes, brief in nature, less than 1 minute. The owner panicked, so didn't palpate the apex beat or check gum colour. It's quite often the case. Sometimes if you ask them carefully and say, did you check the heart? They will have actually checked the apex beat without realising it. And so sometimes you get a clue as to whether there's a bradycardia or a tachycardia, because you'll just say, was it slow? Was it fast? And you can sometimes actually ascertain if there's an arrhythmia there. Just, they won't have even known they've measured it, and they'll just know. Quick recovery, no pre and post ictal phase. The owner has been constantly monitoring sleeping respirate, and that was less than 30, so we're happy there. No other symptoms. So the current medications, you can see we've got the SPAF, the optimised congestive heart failure medications there, and also we've got the fish oils. And we ruled out a metabolic cause of collapse, biochemistry, electrolytes, haematology, all within reference range. So on clinical examination, we found pale pink mucous membranes, heart rate was 160 and regular, no pulse deficits, grade 4 pansystolic left apical and grade 4 pansystolic right apical heart murmurs, peripheral pulse quality was weak, there were no pulse deficits, rest rate was 28, no increased lung sounds. So it's got advanced heart disease. The likelihood is it's probably collapsing because of its heart disease and based on the history as well. So we're going to have a vote now. So if you just want to refresh your browsers, what would you all like to do next? Would you like to A, repeat the cardiac workup, B, fit a 24-hour Holter monitor, so that's an ECG monitor, C, both of the above, D, none of the above, I'd do something else. And we don't mind if you're controversial. Okay. Okay, we've got some 4% controversial here. Okay, but the majority of you would do both of the above, and that's what we did. So, generally speaking, the two most common causes of collapse or cardiac collapse generally are either an intermittent arrhythmia or pulmonary hypertension. Okay? So we measured blood pressure, it was normal, 140. The ECG, relatively unremarkable for a dog with advanced heart disease. It's got some changes there, suggestive of left ventricular, left atrial enlargement, but sinus rhythm otherwise. Echo, again, this is the right parasternal four-chamber long axis view. We can see a huge left atrium, no surprise there. We know it's got advanced heart disease. We can see thick and nodular mitral valve leaflets. There's a bit of prolapse there. That's where it buckles back into the left atrium. We know that means that we've ruptured some minor chords at some point. Not really surprised by any of this. However, what we did see was this. Okay, so we're now looking at the right heart. And that bluey-green jet is tricuspid regurgitation, okay? So we saw that, and we thought, right, let's interrogate that, because interrogating this will tell you about pulmonary pressures, and I'll explain why in a minute. So we measured the velocity of the regurgitant jet on the right side, this is, and it was 5 meters per second. Now, just to give you an idea of what the normal is, it shouldn't exceed 2.8 meters per second, okay? It should be, we've got low pressure side on the right heart. All the right heart has to do is pump blood to the lungs. It doesn't have to pump it around the body like the left heart. So we're dealing with low pressures on this side. So the velocity should be less than 2.8 meters per second. Anything higher than this would suggest either pulmonary hypertension or pulmonic stenosis, and we've already echoed this dog previously. It didn't have pulmonic stenosis. So this is just another angle. Again, we can see the heart's upside down, and that bluey-green jet is tricuspid regurgitation there. For those of you who do like to do a bit of echo, I would advise, if you're trying to interrogate these jets, that you look at multiple views, because it can be quite difficult to align with these jets. So what does this tell us about pulmonary pressures? How do we know what the pulmonary pressure is based on that tricuspid regurgitant jet? Well, basically, we use something called the Bernoulli equation to calculate a pressure gradient. The Bernoulli equation says that 4 times the velocity squared gives you the pressure gradient. So we did that. We did 4 times 5 squared, and we got 100 millimeters of mercury. So we know that the pressure is 100 millimeters of mercury on a side of the heart that should be low pressure. It should be less than, well, it should be 25 millimeters of mercury. So it's 4 times the pressures that it should be on that side. So this dog has got severe pulmonary hypertension, okay? And we know that that's a common cause of collapse. So to summarise, the dog had advanced mitral valve disease and pulmonary hypertension, where you could say, well, you can't rule out an intermittent arrhythmia. So, okay, we sent the dog home wearing a Holter monitor, and amazingly it collapsed wearing it, because they don't always collapse when they wear the Holter monitors for 24 hours, but this one did. And it had sinus tachycardia at 180 beats per minute during the collapse. So I am convinced that it wasn't an arrhythmia causing the collapse. So we treated its pulmonary hypertension, and the dog stopped collapsing. So how do we treat pulmonary hypertension? Well, we have already got the dog on optimised doses of heart failure medications here. So we're going to add in sildenafil. You might know it better as Viagra. Sildenafil is a phosphodiesterase 5 inhibitor. It selectively vasodilates the pulmonary vessels. so it reduces the blood pressure in the lungs and the dogs stop collapsing. You do need to be a bit careful if you have heart failure to go easy with a sildenafil, because you can actually make them worse. So that's just a small warning. So this brings me to my final slide, really, which is January has now, well, BVA have said that January is now the Canine Health Scheme. I don't know if many of you follow them on Facebook, but I wanted to mention this because I'm very proactive when it comes to preventing disease rather than curing disease, and I think prevention is always better than cure. And for those of you who follow me on the Cheshire Cardiology Facebook page, you'll vouch for me there. There are heart testing schemes available, not just for Cavaliers, but for all breeds. So even the Cavapoo breeders, we can test the dam and the sire. It's hopefully soon. We've been heart testing for decades, but we're hoping soon that the Kennel Club and BVA will recognise the heart testing just as they do the hip dysplasia and the hip scoring. We've got a meeting next week with the Kennel Club, so hopefully that will start to be recognised and then advertised. And I guess what I'm trying to say is, for you guys out there, we want you to spread the word, because it's not just for your breeder clients, it's also for your puppy owning clients. There are people going out to buy puppies. They need to start asking to see these heart test certificates, and if they don't ask, the breeders aren't going to have the heart testing done. It's purely voluntary. So I would urge all of you to recommend that to anybody who you know that's thinking of buying a puppy. And on that note, I forgot to mention the Veterinary Cardiovascular Society. They're a really friendly society, and for those of you inspired by cardiology, I would urge you to join it. It's only £25 a year. We meet twice a year, and they're really good meetings. The website's at the bottom here if you want to join. For those of you who just want to know more about heart testing, maybe for your clients, there's also some information on that website there as well. So please do visit that website, and thank you all for listening. Do we have time for questions? Or? Yeah? Okay. Do we have any questions?